Welcome to KJR SummaryCast, audio summaries of peer-reviewed articles published in the Korean Journal of Radiology. Designed to enhance reader convenience and the overall KJR experience, SummaryCast provides conversational audio overviews for time-constrained listeners and mobile-friendly learning. This recording was created using a combination of AI tools with oversight from the KJR editorial team or the article's authors, including necessary edits and corrections. For the most accurate and complete information, we encourage you to also read the original published article.
Welcome to SummaryCast. Today we're looking at a major shift in how chronic liver disease is understood and imaged.
A really big shift. We're talking about metabolic dysfunction-associated steatotic liver disease, or MASLD. It's now the fastest-growing cause of chronic liver disease, affecting, roughly 30% of the global population. It's a huge number.
And imaging is right at the center of it. We're diving into a review article that lays out the entire landscape.
That's right. The paper is titled Imaging Evaluation for Steatotic Liver Disease, published in the Korean Journal of Radiology. The listed publication date is in Volume 27, Issue 2 for 2026.
Okay, so let's start with that name, MASLD. The paper notes this is a new term. Most people are probably more familiar with non-alcoholic fatty liver disease, or NAFLD.
Exactly. The shift from NAFLD to MASLD in 2023 was a big deal. The authors point out that the old terminology was problematic because it was defined by what it wasn't, non-alcoholic, rather than what it is. It was an exclusionary diagnosis.
So it was defined by the absence of something else. What's the new definition based on?
It's an inclusive one. The diagnosis of MASLD requires two things: evidence of hepatic steatosis, that's the fat in the liver, plus at least one cardiometabolic risk factor. It's a more direct and defining set of criteria.
And it gets rid of the word fatty, which the paper notes was seen as colloquial and stigmatizing. So MASLD is the broader condition. The paper also mentions MASH, metabolic associated steatohepatitis. How does that fit in?
MASH is the more aggressive inflammatory form of MASLD that drives the progression to fibrosis. And a key point from the article is that a definitive MASH diagnosis currently requires a liver biopsy to identify specific histologic features like inflammation and hepatocyte ballooning.
And that's invasive, observer-dependent, and subject to sampling errors.
Precisely. This is why the search for accurate, non-invasive imaging is so urgent to replace or reduce the need for biopsies. This review focuses on the non-invasive tools for assessing the two key features of MASLD. First, the steatosis itself, and second, the subsequent fibrosis, which is the main determinant of clinical outcomes.
Okay, let's start with steatosis. Where does conventional ultrasound fit in? It's usually the first line.
It is. It's accessible, cost-effective, and non-invasive. The principle's pretty straightforward. In steatosis, fat droplets in the liver cells act as extra scatterers for the ultrasound beam.
So the liver looks brighter, more echogenic than the kidney or spleen.
Exactly. You also see other signs like blurring of deeper structures in blood vessels because the fatty tissue attenuates the beam more. The paper has a great series of images in Figure 3 showing this progression from mild to severe disease.
But it's qualitative, right? It's an eye test.
It is, and that's the main limitation. It's operator and reader dependent, lacks objectivity, and can be confounded by other conditions like fibrosis that also increase echogenicity. Plus, it's often limited in patients with a high BMI.
A key risk group for MASLD. That's a significant limitation. So how do we make it more objective?
That's where quantitative ultrasound, or QUS, comes in. These are more advanced techniques that measure specific acoustic properties of the liver tissue. The paper focuses on two main parameters, the attenuation coefficient, or AC, and the backscatter coefficient, or BSC.
Define those.
The AC measures how much acoustic energy is lost as the sound wave travels through the tissue. More fat means more attenuation, so a higher AC.
And BSC?
BSC quantifies how much of the ultrasound beam is reflected back to the probe. Since fat droplets scatter the beam, more fat means a higher BSC. They're related but not identical, so they can provide complementary information.
So we move from a subjective visual assessment to actual numbers. Is it accurate?
It's quite good for classifying patients as having steatosis or not, so it's useful for screening. But the paper points out a limitation, a saturation effect. At very high fat fractions, around 34% in one study, the AC and BSC don't increase as much, making it harder to measure changes.
What's the biggest hurdle for QUS in practice?
The authors are pretty clear on this. Substantial variability among different vendors. The proprietary algorithms for acquiring and processing the data are different, which can lead to poor intersystem reproducibility.
So a measurement on one machine might not match a measurement on another. That's a major barrier for longitudinal monitoring.
It is. Until there's a standardized approach, the recommendation is to use vendor-specific cutoffs and, crucially, to perform follow-up exams on the same system.
Okay, let's pivot to CT. How is it used for steatosis?
Very similarly to US, it doesn't measure fat directly, but rather a property related to it. In this case, X-ray attenuation measured in Hounsfield units, or HU. Fat is less dense than normal liver tissue, so a fatty liver appears darker or more hypoattenuating.
And are there established thresholds?
There are widely used ones, though not universally established. The paper mentions a common threshold is a liver attenuation of less than 40 HU on a non-contrast scan. Another is when the liver is at least 10 HU less than the spleen.
How does that perform?
It's decent. One study cited found that a threshold of 48 HU or below on unenhanced CT had 57% sensitivity and 88% specificity for steatosis. For more significant disease, over 25%, those numbers improved to 72% and 95% respectively.
What about contrast-enhanced CT? Most abdominal CTs are done with contrast.
That complicates things a lot, due to variations in contrast timing and enhancement, but the paper mentions research into post-contrast thresholds, with one study suggesting that an attenuation of less than 80 HU had 78% sensitivity and 93% specificity.
That sounds like a perfect use case for opportunistic screening.
Exactly. CT isn't recommended for the sole purpose of screening for steatosis because of the ionizing radiation, but if a scan is already being done for another reason, these thresholds can help flag the disease incidentally.
Got it. So ultrasound is accessible but subjective, QUS is more objective but has vendor issues, and CT is opportunistic. This all seems to be building towards MRI.
It is. The review makes it clear that MRI is the most accurate and robust non-invasive method. Unlike ultrasound or CT, MRI can directly measure the presence of fat.
How?
It leverages the fact that protons in fat and water resonate at slightly different frequencies. This is called the chemical shift. By acquiring images at specific echo times, you can separate the signal from fat and water.
This is the in-phase and out-of-phase imaging that many radiologists are familiar with.
Right. The classic dual echo approach allows for a qualitative assessment, but to get a really accurate quantitative measurement, you need more advanced methods.
And that's proton density fat fraction, or PDFF.
Precisely. PDFF is a biomarker that directly measures the fraction of mobile protons in tissue that are attributable to fat. It's computed using advanced chemical shift encoded MRI, or CSE MRI, which corrects for a host of confounding factors like T1 bias and T2 star decay.
So, it's a much cleaner, more direct measurement of fat content.
It is. The paper calls it a highly accurate, reproducible, and robust biomarker. A meta-analysis of over 1,600 patients showed it has excellent linearity, bias, and precision, even across different scanner manufacturers and field strengths.
That's a huge advantage over quantitative US.
A massive one. It makes PDFF an ideal endpoint for clinical trials of new drugs and for longitudinal monitoring in clinical practice. The general cutoff for steatosis is around 5%.
What's the catch? Is this a standard sequence?
That's the main hurdle. It requires a specialized sequence that isn't available at every institution and may not be part of routine abdominal MRI protocols. It's often part of a dedicated diffuse liver disease protocol.
So, access is the main issue.
Yes, for now. But there's interesting work being done on the opportunistic front here, too. The paper mentions deep learning models that can infer a PDFF value from conventional in-phase and out-of-phase images without needing the dedicated sequence.
Figure 7 shows an example of this, and the AI-derived PDFF is remarkably close to the ground truth.
That's clever. It could dramatically expand screening capabilities using existing scans. Okay, that's a good summary of steatosis assessment. Let's switch gears to the other key component, fibrosis. Why is this so important?
Because liver fibrosis is the primary determinant of liver-related outcomes in MASLD. It's the scarring that leads to cirrhosis and its complications. The severity is typically staged histologically from F0, meaning no fibrosis, to F4, which is cirrhosis.
And again, the goal is to stage this non-invasively. The main tool here is elastography, right?
Correct. Elastography doesn't measure fibrosis directly. It measures liver stiffness, which serves as a proxy for fibrosis. The underlying principle is that a scarred, fibrotic liver is stiffer than a healthy one.
Let's start with ultrasound elastography. How does it work?
It involves sending a shear wave through the liver and measuring how fast it travels. A stiffer liver allows the wave to travel faster. There are a few common methods.
The paper mentions 3, VCTE, PSWE, and 2D SWE.
Right. VCTE, or Vibration-Controlled Transient Elastography, often known by the brand name FibroScan, uses a mechanical probe on the skin to generate a shear wave. Point shear wave elastography, or PSWE, and 2D SWE both use an acoustic pulse from the ultrasound transducer itself to generate the shear wave.
And what's the output? A number?
Yes, the system measures the shear wave speed, and that speed, measured in meters per second, is then converted into a tissue stiffness value, typically reported in kilopascals or kPa.
What are the main advantages here?
The main advantages of ultrasound elastography are its portability and relatively low cost, which make it well suited for point-of-care use in clinics.
But what about the limitations? I'm sensing a pattern here.
There are several. First, accuracy can be affected by factors other than fibrosis, like acute inflammation or even just eating a meal, which can transiently increase liver stiffness. Second, there are high rates of technical failure in patients with obesity, a key risk factor for MASLD.
That's a major drawback. What about consistency?
That's another big issue. Like with QUS, there's only moderate concordance between vendors, and even with the same vendor, reproducibility can be a challenge. One study cited found that the reproducibility coefficient for VCTE was 36%, meaning serial measurements could differ by that much due to variability alone, not a true change in the liver.
So a change has to be pretty large to be confident it's real.
Exactly. This brings us back to MRI again, with MR elastography, or MRE.
Okay, how does MRI work?
It's a similar concept, but a different execution. A small pager-like device is placed on the patient's abdomen, which generates continuous low-frequency mechanical waves that travel through the liver. A specialized MRI sequence then measures the propagation of these waves.
And what are the advantages over ultrasound elastography?
There are a few big ones. First, it assesses a much larger portion of the liver, making it less susceptible to sampling error. Second, it has substantially better agreement between vendors. And third, it's highly accurate and reproducible.
Quantify that. How much better is the reproducibility?
A meta-analysis showed MRE has a repeatability coefficient of around 20%, significantly better than the 36% for VCTE. The paper also discusses 3D MRE, an even more advanced technique, which pushes that down to just 11%.
That's a big improvement for longitudinal monitoring, and it's not affected by obesity.
Correct. A pooled analysis showed it can accurately detect fibrosis across all stages, independent of body mass index. It's also not affected by steatosis itself.
So what's the catch with MRE? It sounds almost too good.
The usual suspects for advanced MRI: cost and accessibility. It requires specialized hardware, the driver that generates the waves, and software that not all institutions have. It also takes longer to acquire than ultrasound elastography.
And I assume it's not for patients who can't undergo MRI.
Right. Patients with certain implantable devices may be ineligible. So while it's technically superior, ultrasound elastography remains more widely used in clinical practice due to its accessibility and lower cost.
So we have this toolkit of imaging biomarkers for both fat and fibrosis. Where are things trending? The paper has a section on emerging directions.
This is where it gets really interesting. A major focus is on developing biomarkers that can capture inflammation, the key component that separates simple steatosis from the more aggressive MASH.
And what's being explored there?
One promising technique is corrected T1 or CT1 mapping on MRI, which accounts for iron deposition and shows promise for assessing inflammation. 3D MRE can also estimate a parameter called the loss modulus, which has been proposed as a marker for inflammation.
So moving beyond just fat and stiffness to a more complete multi-parametric picture of the disease.
Exactly. Another major theme is the role of deep learning in AI. We already talked about AI for inferring PDFF from standard MR images. Another exciting application mentioned is generating virtual MRE maps from conventional MRI and clinical data.
So you could get a liver stiffness map without ever performing an MRE sequence.
Potentially, yes. One study showed a model that could predict clinically significant fibrosis with 78% accuracy this way. This would be a game changer for opportunistic screening, allowing clinicians to identify early-stage disease without dedicated imaging.
And I imagine AI could also help with automating the analysis itself, like placing regions of interest to reduce operator dependence.
Absolutely. It has the potential to make these quantitative techniques more efficient and more reproducible.
So to wrap this all up, what's the big picture takeaway from this review?
The big picture is that the management of MASLD is rapidly moving away from invasive biopsy and towards a reliance on non-invasive imaging. We have an expanding array of tools, each with its own strengths and weaknesses, from accessible ultrasound to highly accurate but less available MRI techniques.
And the field is pushing towards more quantification, more standardization, and leveraging AI to improve both accuracy and accessibility.
You nailed it. The authors emphasize the pivotal role that radiologists can play in shaping these developments by adopting standardized protocols like the KIBA profiles, contributing to clinical guidelines, and embracing these new quantitative tools.
The review certainly points toward a fundamental shift in radiology's role, moving from qualitative interpretation to providing precise, quantitative biomarkers.
That's a great way to put it. It's a very comprehensive look at a rapidly evolving field.
Thanks for listening to SummaryCast.